As we know, we see 90% of the patients in the NHS on less than 10% of the budget. And so we've got 10 minutes to do that. Not only to do that, to do our documentation, to do all the necessary paperwork after it. Hi guys, in this video, I'm going to be showing you key consultation skills that will not only ensure your success in the RCGP SCA, but make you a better clinician. Today we are going to be discussing a very central issue, and that's the consultation skills that we need to succeed not only in the SCA, but to succeed in our coming GP career. The learning objective for today's teaching is to bring us to the understanding of the importance of effective consultation and to show us how to approach different clinical scenarios and know exactly what we've been doing wrong. And at the end of the teaching, I would expect everyone to be able to develop a consultation skill and model that work well for them, and they know exactly how to use it, which is why I would just mention once again that everyone please get your pen and your jotters out. So why is what's a consultation? It's a meeting between a doctor and their patient where the doctor listens to the patient's symptoms and explore their illness. They listen to their concerns and formulate management option which they are sharing with the patient. It's that process that lets the doctor collect information from the patient and convert them into well-established medical constructs. It's a process where diseases and versus illness situation is fully explored. And in the last webinar, I mentioned how diseases are completely different from illness. Diseases may be treated in the hospital. We do not treat disease, we treat illnesses. And we will come to that in a moment. So what's the whole point of the consultation skill? Because if you see a GP or a GP training everywhere, all they are talking about is consultation skills. So what's so important? Well, it is the trademark skill of the general practitioner. This is our skill. So if we do not have this skill, one cannot be a good general practitioner. There is greater patient satisfaction when the skills are there, leading to less chances of complaints. And even the patients as well, they're likely to be adherent to the advice we've agreed upon. And you also finish the consultation happy because the doctor then becomes very effective. He spends less time seeing a patient, and so he has more time to do other things. Primary care consultation is quite unique, and it's new to many of us, especially those who are coming from the hospital, because we see undifferentiated condition. A patient can come to meet us and give us 3 symptoms, and the 3 symptoms can mean 1, 2, or 3 different illnesses. But the main reason is because we have limited time, and of course we have limited resources. As we know, we see 90% of the patients in the NHS on less than 10% of the budget. And so we've got 10 minutes to do that. Not only to do that, to do our documentation, to do all the necessary paperwork after it. So if the skill isn't learned, the simple truth is that many are just going to burn out because we're not going to be effective. We'll spend 30 minutes on our consultations, and when we ought to be leaving the surgery by 5 o'clock, we'll be leaving by 7 o'clock, 8 o'clock. So it's a skill that helps us to draw the patient into their own health and treatment such that they feel empowered and they are made very equal partners in their own health. So there are important elements we're going to be looking at today. And first will become the communication skills part of it. Second will be the structure And then third will be the use of our consultation tools, which I'm going to be showing you. And those tools will include the use of our two-way steer, which I touched on very briefly in the last teaching, the use of reflection, the use of signposting, receipts, and of course, summary. So as I mentioned, effective communication is the core skill, and it is as important as your clinical knowledge. In fact, many people believe that it's even way more important than your clinical knowledge. It is not about being nice, because many of us make the mistake of, oh, just be nice. That is not what communication skills is. It's not about being nice. And if we do not have it, our knowledge and our intellect can easily go to waste. So it's what puts the theory we know into practice. And it is saying things in a way that the patient will fully understand it, that the patient is comfortable enough to tell you what is on their mind, the real reason why they've come to see you, what's their fear. So in terms of the types of communication, as we all know, we've got the verbal and non-verbal types. The verbal one is the most used means of communication in our consultation. It's not just the speech itself, it's the tone, it's the emotions attached to it. It's the emotions attached to the speech itself. There is an emotion that your face carries, and there is an emotion that what you're saying carries. So if there is an inconsistency between what your face is saying and what is coming out of your mouth, the examiners are going to go, oh, this doctor is disingenuous. And there is the appropriateness side of it, is what we are saying appropriate for that time and in that context. So number one is politeness. We need to be polite. We need to be polite. We need to be firm when we need to be, but at the same time, we need to be polite. We need to be relatable. Does the patient find how we are explaining their diagnosis relatable? And the common example of that is the hypertension scenario. They deliberately made it so much that the hypertension scenario had a plumber in there. And a good doctor goes, you know what, the way fluid and the way water flows through the pipes when you've installed them, and that's the same way blood flows through those pipes in your body. But in your case, the blood is flowing at a very higher rate, using way more force to do that. So he's likely to understand it because we have brought it to what he sees every day. We have brought it to his area of his own expertise. So we are relatable. Does the patient need to ask us to explain? And that's one thing we want to avoid. Oh, can you come again? Oh, what does that mean? Oh, is there anything else? Oh, how do you mean? So those are the kind of things that will hurt our interpersonal skills. So we want to communicate in such a way that as much as possible, at the first time, the patient understands exactly what we're saying and does not need to ask us to explain further. Not only do they understand it, we are that direct, at the same time polite. And the next thing is complexity, is the use of medical jargon. We are very familiar with this word, so it's only natural that we use them. It's only natural, but those are what we need to be careful about. There is the medical English. Those are words that are not necessarily jargons, but the average layperson will not understand them. You are predisposed to diabetes, predisposed. The layperson will not understand it. That it runs in the family, that your uncle had this is a risk factor. They will not necessarily understand it. So even though it's not jargon, it's a medical English that the general population will not understand. And we understand them because they are words that we've used all throughout our careers, all throughout our medical school. So they are words we are used to. So we then need to then begin to unlearn those words in our consultation, finding alternate, simpler and basic words that our patient can easily understand. Another important thing is what we do when we make mistakes. Oh, sorry, I'm a boy. I'm not a girl, and we've addressed them as a girl. Many of the times, what we tend to do is to pretend like nothing happened and we move on. Don't do that. It's going to hurt your interpersonal skills significantly. Acknowledge it. Oh, I'm so sorry about that. I didn't realize. And thank them for it. Oh, thanks for bringing that to my attention. And move on. The same thing happens to when we don't know. Oh, doctor, I've got lipodermatosclerosis, and we act like nothing happened. We act like we didn't even hear it. It's not going to fly in this exam. Address it, acknowledge it. Oh, that's such a long word. It's not something I'm very familiar with. But let's see how the consultation goes. Acknowledge it, address it. And that's very important. And the examiners are looking for how each doctor will address these things, because these are the things that lead to complaints at the end of the day. They are things that lead to complaints. So they are particular and looking, oh, how does this candidate address this situation? Keep it simple. Only say what you say. Oh, I can see that, oh, it's been such a difficult and challenging time for you. And all the patient has said is, oh, doctor, I've got a headache. No, don't do that. Only say what you see or what you have heard them say. Do not assume. Do not assume. You're seeing a man, he's saying he lives at home with his partner. Do not assume the partner is a woman. You're saying two ladies. Do not assume one is your patient, the other is their mom. Do not assume. Only say what you've been told or what you can say. You know, many examiners struggle, especially in that introductory part where you have asked them what brings them and they've told you, and then we go and say, oh God, I'm so sorry, and that. And it's just so disingenuous, and it shows that we haven't been doing it in our consultation. So if they've said something, say it. If you can see something, you can see frustration on their face, say it. I see you're a little bit frustrated about this. Don't go above one, beyond, somewhere in the middle. Another very important one is the sexual history. Many of us will signpost such that we will make even the sexual history become weird. Signpost once, move on, and gradually build up. We will get to that in a minute. Mirror patient's voice. If patients has come and they're excited and they are right up in here, be there with them. If they are low, be low with them in your voice. And as they move their voice, as they move their own voice, you need to modulate yours as well to move in that direction. So we can't have a very high voice and we are breaking bad news. I'm so sorry, Mr. Johnson, but I'm afraid to tell you that you've got cancer, you say. We cannot do that. We cannot do that. The situation, our face, and our voice must be in tandem. Next one is we need to learn to use our one-liners well. Okay. Yeah. And that is part of the receipt that shows that, okay, this doctor is actually actively listening to what I'm telling them. And the last one is to define diagnosis. One of the things I emphasize is that for people to learn how to define every diagnosis, we all think we know how to. We all think, and I've been there, we all think we know how to until we are asked and we realize we do not know. It's a skill we don't know how to do as doctors. So please practice them and get used to at least the common diagnosis. The non-verbal ones will be silence and pauses. A patient has given you what is making them upset, don't jump at it. Give them a little bit of silence. Give some pauses. Let it show that you share in their emotion. Let it show that you're with them. Let it show that they can count on you as a valuable partner in progress. Head nodding, slightly. Hand gestures can go a very long way, and the facial expressions, as I've mentioned before, can be very important, and the same as emotional mirroring, where they've not said anything, when we haven't said anything, but how our face is, our facial expression is mirroring that of the patient. And these are some of the non-verbal things that we need to do. Consultation structure is an organized system by which a doctor approaches a consultation. It's a way of looking and deconstructing what happens in the consultation. I know many of us are aware of various consultation models, but I've mentioned just a few of them. But going through all these models as an ST3, what I realized is that none of them actually perfectly fitted into what I wanted to do, which is recording from my RCA at the time. And what I then did, which I will discuss with us in just a minute. So why do we need consultation structure? It makes us organized. It ensures we never miss anything important. It helps us to know when our consultation is derailing, because you have a plan. So when you are out of the plan, you know. And it's easier for examiners to follow us. Examiners can go, oh yeah, he's in red flags now. Oh yeah, he's trying to exclude differentials now. They know for sure. And what that causes is that it causes effective and efficient consultation, making your time management easier. There is a common saying I usually say, and that show me a doctor struggling with time management, and I will show you a doctor without a consultation structure. And there's the 6 minutes rule. By 6 minutes, a good consultation will be done with the history and approaching diagnosis already by 6 minutes. If at 6 minutes, a doctor is still unsure what's happening, chances are high that they haven't got any structure. So, the consultation is divided into 3 parts. And it is the failure of the examiners to appreciate for certain where this doctor is at every point in time that is the challenge. So we've got the patient part, where the patient tells us in the first minute, and where they tell us their idea, concerns, and expectation. And we've got the doctor's part, where the doctor does the medicine, where the doctor goes, okay, do you have this? Do you have this? And what the doctor does is the information gathering and what we call translation. And translation is the process from which, by which a doctor converts that information is gathered into well-established medical constructs. And there is the shared part, which is the diagnosis, which is the management bit, which we will get to. Now, there is what we call a consultation paradox. The consultation paradox is that when we actually ask less at the start of the consultation, multiple studies have actually shown that the doctor indeed gathers more information. And that is the reason for the golden minute. You will gather more information because you're there using all your non-verbal communication skills, mirroring what the patient is saying. When you sense they're unhappy, your face is unhappy. When you sense they're happy, your face brightens up, and cheering them on to tell you more. And one of the reasons for long and non-focused history is a failure to have the golden minute, the first minute, because the doctor is talking over the patient or wouldn't let the patient talk. So, like I was mentioned, I'd gone through all of them, and what I soon realized is that nothing was actually working. So, and that led me to begin a consultation model which I used for my RCA, which I now use every day in my everyday consultation, and which I have been teaching with a very fantastic success rate. If you want to write it down, I would encourage that and see if it works for you, or it has worked for almost everyone I know. And this is the traditional one. The traditional one is the one where the patient has come to you with a complaint. They've got headache, they've got chest pain, just any symptom they've come to complain about. And the first thing is whatever works well for you. What brings you? How may I help you? What can I do for you? Depending on what works well for you. And what you're asking in essence is that you're asking them their presenting complaints. And when they've asked you their presenting complaints here, if it's a medical term, only if it's a medical term, ask them to clarify. Because we know that many times what patients are referring to and what we understand by that same term as medical professionals are two very different things. So ask them to clarify. Oh, just so I fully understand what you're referring to. What do you mean by reflux? And once you've done that, the second thing is, please tell me more about it. Tell me more about it. And that's the golden minute. And in the golden minute, you then, as they're telling you, you're using your verbal and non-verbal receipts, showing that you're receiving the information right. Okay, I see. And you're taking pauses. And you're facially and non-verbally prompting them. Okay. Like you're saying, go on. And the other thing you're doing is mirroring. This is the time many of the patients show a lot of the emotions. You are mirroring what sort of emotion they're showing at this point. And you're acknowledging what they're saying to you, which, as I mentioned, is not always verbal. And as I mentioned, there is no extreme. Only say what you say. Only mention emotions you're certain about. But don't forget, this is the patient side of the consultation. So let them speak. Many of the patients are trained to give you some portions of your eyes at this stage. It now depends on you. You can choose to address it right now. Or if you're going to address it now, you're going to reflect the portions they've given you already. Oh, you mentioned that you think this might be a chest infection, but I wonder what worries you about this. So use what you have to get what you need. And if you choose to address the eyes later, based on what they've told you, you mentioned that you think this might be a chest infection, but I wonder if you could tell me a little bit more about this cough, or you could just go into your history of presenting complaints there. That's your two ways here, where you acknowledge what they're saying, or you go in the direction you want to go, only to come back and reflect it later on. Each system has its advantages, it has its disadvantages. If you're someone like me, that I like my line of thought to go straight, I would recommend to do it later on. If you're someone that is likely to forget, or to forget the portion they've told you, I will recommend that you do it now. The good news is you are not going to hear anything like you're the doctor, because these are trained patients. If you do it too early, the risk of hearing that is really high, because you've not got to meet them, you don't know them, you've not established rapport with them, and you're asking, so what would you like me to do for you today, Mr. Smith? He's going to say, oh, you are the doctor, tell me. So, but it won't happen in this exam because they are trained. So, and that's the problem with doing it now. Doing it later, forgetfulness is there, but it also has the advantage that you've gathered a lot of information, you've gathered a lot of weapons to use to get what you need out. And number one is the first signpost. the first signpost. Why do we signpost there? We signpost there because you're telling the patient, you've had your time, shut up now. Now is my time. That's what you're telling the patient. And the trained patient will get the memo if you signpost. I'm going to ask a couple of questions now just to help me put this headache into more perspective. I'll put the symptom there. Please don't use symptom. Use the headache. Use the chest pain, whatever symptom it is they've come with. I'm going to ask a couple of questions now just to help me understand this chest pain a bit better. And then fully explore the history of presenting complaints. What's the location? What's the onset? What's the character? What's the severity? What's the aggravating or relieving factor? What's the cause? Is it getting better? Is it getting worse? What's their response to treatment like? Very important. Very important. Some of you have some acronyms you use in here. You can use them. Very important. And then don't ask them if there is any other thing. They will ask you like what? Because what you're saying is that you're trying to get information out, but what they are saying, what they are hearing is, tell me the secret here. Tell me the secret. That's what they are hearing. Tell me where the information is hidden. Lead me there. And so that's why they get triggered by it. After that is your second signpost. And your second signpost is your differentials. We ask a couple of questions to exclude some possibilities. I will ask you some yes or no question just to help me work out for sure what's causing this headache. Just because a lot of things can behave like this, I will ask a couple of questions just to help me know which of them is which, or which of them is causing this trouble for us. But when you signpost, do what you said you will do. Imagine me putting in my door that you come in, I've got jollof rice, and you come in and you find no jollof rice. That's how frustrated the examiners can be when you've signposted and you are not doing what you've said you will do. Your questioning must be back to back. Do you have this? Do you have this? Do you have this? 3 questions for each differential. The 3 questions for each differential must be back to back. It's no time for, okay. You said it's headache, yeah? No, it's no time for it. You have sent out the memo that now it's your time to do things with it. So in your 3 minutes, when you're waiting, that's presenting complaints you've seen, write 3 or 4 differentials of it, and in the differentials of each of them, write 3 or 4 symptoms down. Now, many of us, once we get to what we believe the diagnosis is, if it happens to be the first or the second differential we exclude, we are like, yeah, we got it, nail it down. Just to be clear, you said this cough gives you greenish sputum, and you did mention that you're unwell with shivers and cold. Is that correct? You're telling the examiner, listen, I did not manufacture the diagnosis, I've arrived at it. But when you've arrived at it and you have still not excluded enough differentials, do so. Is there any chest pain at all? Is there any pains in your calf? Do you feel short of breath, especially when you take a deep breath in? Or when you've gone for a walk? Specific 3 back-to-back. Third signpost is your red flags or complication. I will just ask a couple of questions to help me exclude anything sinister. Just to make sure nothing dangerous is happening, I will ask some clarifying questions. There is no patient that hears that won't go, this doctor knows what he's doing, she knows what she's talking about. Let me do as told. 1 or 2, they are usually enough. Let it be what is relevant to the diagnosis you've established. relevant, and a possible complication of it. Let no one come with Bell's palsy, and then we are excluding differentials of stroke. No. So let it be possible complications of what's happening. So one or two complications, 2 or 3 questions, they are usually fine each. Third signpost. Once you're done with that, you can then go to the psychosocial history, which is what the illness is. In the psychosocial history, use what you've been told to get what you want. You mentioned how difficult it's been for you at work. I'm just wondering how have you managed to cope at all? You've described a few problems at home. How are you getting on at work? Any support at all? Any close friend? Any family? Why the psychosocial history is very important is that it's the one that helps you to get what the illness is. An illness is what a disease means to some. If we do not get what the illness is, we cannot do primary care management. We cannot. Because what we've taken from them is what an hospital doctor will. We cannot. And that's why the psychosocial history is that important. Relevant past medical history, medication history, only if relevant, can be a very powerful way to exclude some differential symptoms. You are suspecting someone is having AKI, and in the medication history that I can see you're not on any medication that could cause this problem here. But do you take any over-the-counter painkillers? You are excluding a differential, judging by what you already know. And if you are suspecting the patient is having a disease condition as a result of side effects from a medication, ask directly. Just because some medications can cause this kind of problem, and I see that you're not taking it, do you take it over the counter? But make sure it's an over the counter medication. Same thing with the family. Just because some of these things can run in the family, does anyone in the family suffer from hypertension? Social history, only if relevant. Don't take history for smoking and alcohol in an ankle sprain, only if relevant. And signpost as well. Just because some of our habits can play a role in our health. I wonder, do you drink? Do you smoke? For young patients who have come with sexual health issues, ask about recreational drugs. For young patients who have come with symptoms you don't usually expect in a young person. For instance, you've seen a chest pain that's not fitting into any particular type. Ask about recreational drug. And if you're asking, signpost it so that the examiners know that this doctor is not just asking because he's attended the course and they said, oh, ask. No, but because he knows why he's asking. So we need to follow patterns, as they usually tell us back in Nigeria that common things occur commonly, don't they? Sexual history. We need to signpost. Sorry for the mistake. So I wrote it down, but don't be weird. Build it up. Start from, are you sexually active? Don't go, so when last did you have intercourse? No. Are you sexually active? Who is their sexual partner? Is it a male or a female? Don't assume because you're seeing a female patient, their sexual partner is definitely a male. If they've said they're sexually active, and then ask all other things you need. And the next one is your ideas, concerns, and expectation. Like I mentioned, we'll reflect on portions that's already been mentioned, and then use it to ask the other ones. You mentioned you're a bit worried about cancer, but But what would you like me to do today? How would you like this to be addressed? Know 2 or 3 phrases through which you will ask each of the elements of ICE. What do you think this is? What do you think is going in here? You mentioned you checked over the internet. So what did you come up with? Don't ask multiple times. If you're caught doing that and the patient goes, "Oh, you've asked me before, doctor," don't pretend nothing happened and move on. Apologize, acknowledge it, apologize. You could even stress the important. I mean, I know I may have asked, but just because this information is quite important, that's why I asked again. I apologize. Move on. Diagnosis. Your diagnosis starts by refuting what wrong ideas the patient has. They think it's cancer. Oh, thankfully, for X, Y, and Z reason, this isn't cancer. It's not looking like cancer. What it looks like is this, and this for X, Y, and Z reasons. So explain the diagnosis, show your workings, let the examiners see your thought process. Let them see that this doctor is working things out. And that's what the examiners want to say. And once you've done that, check the knowledge. Have you heard about cancer before? Have you heard about hypertension before? Yes, no. What do you know about it? If it's correct, reinforce it. Oh, you're absolutely right. There are a couple of things we can do here. Reinforce it and move on. If it's not, explain it. And that's the place of knowing exactly how to explain diagnosis. Please learn it. But we'll get there anyway. So if not correct, explain. Make sure they've got the right information. Learn it. If you go on NICE and you click background, you will see definition there. Or you could use patient.info, or you could use the various NHS materials available. Just the main major disease conditions that you can think about. Write them down, learn them, memorize them. There must be a diagnosis. I attend a lot of role plays, and one of the things I see is that no diagnosis. Without diagnosis, you have surely lost the man. In fact, without diagnosis, I think it's going to be difficult to actually pass the station without diagnosis, because what would you be managing? What would it be managing? But the dilemma is when you are not sure what the diagnosis is. Be broad enough such that you cannot be wrong, and be non-committal enough so that you cannot be wrong. Someone has got low back pain. You've taken a good history. You're still not certain whether this is sciatica. Why are we saying, oh, it's sciatica? Low back pain. You're going to get your mark. Someone has come up with a chest pain. You're not certain it's a musculoskeletal pain, but you know it's not a cardiac pain. Tell them non-cardiac chest pain. Don't go into the fine details of something you've not been able to clarify in the history. It's not going to fly in this exam. So be broad enough in that context. Management is mobilize all information you've gathered, every single thing you've gathered. If there are specifics, you've seen you've seen someone who's come for contraception. You've identified other issue you want to discuss. Oh, I would like to mention this, and this. However, because of time, the examiners know that you're thinking about it, especially if they're important to that case. Talk less. Do 50% of the talking. Let the patient do 50% of the talking and decision making. Address primary care management. How has it affected them? Deal with that. The blood tests, the referrals, they are good. But if a doctor does not address primary care management, the patient is going to struggle before they get that blood test done. If they're alone at home, ask them about friends. Ask them if friends can come to visit them, if they can ask friends to come. If no one, ask them if they won't mind the befriending service. If you would like, if they would like the social prescribers to see them. Deal with all those things. They drink alcohol and it's central to the case, deal with it. They smoke, it's central to the case, deal with it. You identified poor compliance, deal with it. That is what primary care management is. Give them options. If you want to bring them to examine them, don't just say, yeah, we will bring them. And, I've heard this a lot of times. We always ask this question. It's not a reason. Explain why you're asking. I forgot about this. If you're asking a question because of this and reason, that's why I'm asking. Not that we always ask. We always ask is no reason to ask. So if you will bring them in to examine, say what you want to do. Your safety netting, the RCGP released guidelines guiding safety netting 2 years ago. For those of you that didn't see it, please, if you can go back, I think it might still be on the website, and it's that the safety netting should be appropriate. It should be appropriate. You've seen a chest infection, you've started them on antibiotics, they can get sepsis from it. So if you do safety netting of sepsis, it will be completely appropriate. But you see someone with a lateral epicondylitis, and then we tell them about stroke, it's not going to fly. Let it be only a possible complication of your diagnosis. Now, what we've dealt with is the traditional one. What's the non-traditional one? The non-traditional one is the one you use when they are coming with things like follow-up. Maybe they've been seen in the hospital, they've been seen by your colleague, or you've seen yourself before, and they are coming back to review their investigations, their blood test, or whatever. Or it's a chronic illness and they're seeing you for disease monitoring or the annual review. The history in here needs to be more concise. If you need to finish your history by 6 minutes in the traditional one, in here you need to finish quicker, because there will be many other issues that would have been put in the question for you. So you need to finish quicker so you can address those. And to do that, there need to be a plan in place. And the plan in place is that there are several people who have got various mnemonames on solving this, but do a background first. How did we get there? Oh, as you know, I'm saying it for the first time. Could you talk me through everything that has happened to you? And that's your golden minute. Allow the patient talk. As usual, use your receipts, use your prompts. When they are done, clarify gray areas, and then follow the lead of the patient. There are patients that are pushy, that want the results right away. You could give them right away. But if you give them right away, don't forget you still have a job to do in order to get all your marks in your data gathering. So when you've given them, tell them that we're going to be discussing how to sort this out, but just so I fully understand everything and I take everything into good context, could I ask you a couple of more questions? And then you fire on. If they are not so pushy and they are willing to wait, do your history as you would normally, and then come to the results later on. Where are we now? Is it getting worse? Is that new symptoms? The treatment they've received, that they worked, what treatment exactly have they received, that they compliant on it, and the side effect of medications, what do they think about it? Do they think things are going in the right direction or not? That's what we need to address now. And once we are done with that, we then go on to differentials. Back to back as usual. Signpost, but we do what we do. We have said we will do in the signpost. And then we do an history of complications. 1 or 2 will be completely fine for 2 or 3 questions each. And then we carry on with the rest of the history as we would for a traditional presentation. If at any point in time we feel stuck, summarize. Don't summarize with everything the patient has told you. Oh, so Mr. Smith, you said in 1979, this thing has started. No, don't do that. You've got long-standing chest pain that comes on and off. Now it's coming more frequently. You've got shortness of breath with it. You're worried this might be an heart attack. That's all. If you feel stuck. And then once you've summarized, ask the patient, have I missed anything now? Because there are elements that the patient believes are very important. And they will raise that. And that is likely to be their concern. But you are not assuming it is. Don't summarize more than once, at most twice. If you are not stuck at any time and you don't need this tool, you won't be penalized for not summarizing. But what summary does is that it helps you show you're working, but you do not, definitely do not have to use it. Like I mentioned, if you've forgotten anything, decide if taking the history now in the middle of your management is going to change your management or not. If it certainly would not change your management, don't ask. If it would, acknowledge it. Oh, I should have asked this. But just because it could play a central role in what we do here, you see. Do you smoke? So acknowledge it, apologize, state the importance, and ask. So write your plan down. Make sure you have a plan. Write it down. If you're getting on well with my plan, use it. If you're not, use what you're getting on well with. Use it daily, not just in your role play, but even in your surgery. Self-role play. Sit down in front of your mirror. Give yourself all symptoms from head to toe. Now it's headache. Run the headache. Now it's chest pain. Run it. Eye pain. Run it. Ear discharge. Run it. Chest pain. Run it. Spend your 3 minutes wisely. Forget about what has happened in the last station. Spend it writing down your 3 or 4 differentials, writing out 3 specific symptoms to ask for each of them, and your complications that you will ask. Be flexible. Make changes to the structure as appropriate. If the patient is pushy, they want their results now right away. Don't insist. Oh, no. I must ask these questions, Mr. Smith. I'm afraid I must ask first. So once I ask, then we will deal with others later on. No. Follow the patient's lead. Accommodate your own strengths and weaknesses. Thank you so very much. Thank you for listening.